so much for joining us for the June edition of Lunch a la Carte. We appreciate each of you taking your time, whether you're here with us live today or you are watching us on our recording on YouTube. I have a couple of quick announcements for you guys. If you have not yet signed up for the recurring giving program for CART, what we call affectionately the Roger Ackerman Circle, please remember you can do that by visiting mycartfund.org, signing up for your recurring gift. I know many of you on this call are already recurring donors and have received your Roger Ackerman Circle pins. We still are getting those out to everyone, but as of today, we're up to 138 recurring donors. So we thank you for your support of that. Just a reminder that Governor Tammy Mosteller from District 7670 is working on a new cause-based Rotary Club. You're going to be hear more about that in the months to come after she is no longer governor and has a little more time on her hands. And that is going to be a cause-based Rotary Club looking for support for CART and working on Alzheimer's and dementia research and awareness and fundraising. So we're excited about that. If you have questions, feel free to send her a private message or post it in the chat and one of us will get back to you. Want to remind you that we now have all of the Zoom links and all of our complete schedule on the calendar on our website. You can find that at cartfund.org. So if you can't find the Zoom link at the last minute, you can simply go to events and fundraisers and then find the calendar on our website, go to the date that you are looking for, and everything will be there that you need. We're going to try that for a few months. And if we don't get any bots and spams and unwanted visitors, we will keep that up. And but as a quick reminder, we do use the same Zoom link for every meeting, and that schedule is, as I said, always on the calendar. Speaking of the calendar, there are 10 days left in this fiscal year. So there is still time for you to make a gift to CART Fund by going to mycartfund.org and making a gift by an individual or a club or a district. And we are very excited because for the first time ever, we are breaking all kinds of barriers this year. And as you all know, President Rod issued a very steep challenge to us last year when he became our board president, that he wanted us to raise $2 million in a year when the most we'd ever raised was $1 million. And we are very excited that with 10 days left to go in this fiscal year, we have met his goal. And we have raised $2 million this year. And much of that was, of course, thanks to a very generous gift from one Rotarian in North Carolina of $1 million. And we are so proud and excited to be able to celebrate that. And so I say that to remind you that there is still time for your district and your club to make your donations, because every dollar counts. And we thank you for your support of CART. We are excited that one of our new district director, regional directors, Governor Tammy Mosteller, has taken over the role of setting up these lunch a la carte meetings for us. I am eternally grateful. And she has been working with all of our researchers to set those up for the rest of this year. If you don't have those dates, they are already scheduled through January of 2024, and those dates are on our calendar. And it is my honor and privilege to introduce Tammy at this time so that she can introduce our special guest speaker.
Thank you, Tiffany. And I have absolutely loved working with the CART program. So today I want to introduce Dr. Philip Wong. He is a professor of pathology and neuroscience at Johns Hopkins University School of Medicine. His research focuses on understanding the molecular mechanisms of neurodegenerative disorders such as Alzheimer's, amyotrophic lateral sclerosis, and frontotemporal dementias. He received his undergraduate degree in biochemistry and his PhD in biochemistry and molecular biology from the University of Western Ontario in Canada. He completed his postdoctoral fellowship in cellular and molecular biology at Johns Hopkins University School of Medicine in the Department of Biology Chemistry. Dr. Wong joined Johns Hopkins faculty in 1994, and he's got a few awards behind him as well. Zenith Fellows Award from the Alzheimer's Association in 2004. He was Teacher of the Year 2004 with the Department of Pathology. The Cal Ripken Lou Gehrig Fund for Neuromuscular Research, Johns Hopkins School of Medicine in 97. Postdoctoral Fellowship, Muscular Dystrophy Association in 1990. Leadership and Excellence in Alzheimer's Disease Award, National Institute of Aging, 1994. And he is a recipient of the CART Fund for Alzheimer's Research, from 2002. So I want to thank you so much, Dr. Wong, for being here and sharing with us what's going on in the world of Alzheimer's research.
Well, thank you so much, Tammy and Tiffany, for the invitation and your kind introduction. It's really my pleasure to really meet off you here again and really congratulate you on this triumph, this breakthrough this year of raising more than $2 million for Alzheimer's disease research through your hard efforts. And this is really astonishing feat that you guys are pushing. And I take, all of you really part of this big team to try to solve Alzheimer's disease. And I think with the recent advances, some of the drugs that are in the clinic and getting approved, by the FDA, it really a testament to all of your efforts and how over the years you have really brought to fruition this major challenge that we all face in our society, in fact, worldwide. And so I really want to thank you for all of that. This has been a tremendous effort by all of you in pushing this forward. And I really also appreciate the initial grant, grant that I received more than, well, I guess 2 decades ago now, back in 2002, one of the first few that was given out. And at that time, I still remember meetings, Mr. Ackerman, and talking with him about his vision and how he had really pushed the cart to where we today. So I really thank him as well for his effort through the years. But what I'd like to really tell you a little bit is some of the progress we have been making since that time, and just highlight some of the recent work over the past several years as well, to show you how we been making direct impact on the disease itself. Now, if I can advance. Okay. So what I like to tell you is the one of the biggest hurdle that we need to overcome in Alzheimer's disease research is that we are facing with a complex disease. So Alzheimer's disease, we don't think it's just one single disease entity. It's really comprised of several different subgroups or subtypes of Alzheimer's disease. Much like that of cancer, there are different subtypes. So if you don't direct medicine towards these specific subtypes, it becomes a big hurdle, because then the drugs that you are developing may not treat everybody the same way, or could not treat everybody the same way, and therefore only a certain population, a subpopulation of Alzheimer's patient will respond to certain drugs. So even with the latest antibody drug that we've seen in the clinic, there's only a subset of patients that are responsive to that particular type of drug. So that tells us that we have still some work to do. And this, I think, is one of the major hurdles, is our ability to stratify different subgroups or subtypes of Alzheimer's disease patient. And the other hurdle that we need to therefore clarify is that these pathogenic root causes, right? These root causes, these different subtypes, needs to be understood. Because if we don't understand it clearly, then it would be hard for us to think of ways to treat them specifically, okay? So therefore, we really need model systems that will help us to get to that endpoint, to really understand the root causes of these different types of Alzheimer's disease subtype. And that really again leads to this idea of personalized medicine, so that there will be different patient subtype that will require different types of specific types of medicine. So that is number two, and really these understanding of the complexity of Alzheimer's disease really provides the opportunity for Alzheimer's research in terms of now developing what we call these biomarkers, or these ways that we can actually help us to determine which subgroup or which subtype of Alzheimer's disease you might have. And so bringing these sort of blood tests into the clinic will indeed help us to resolve that critical issue. And of course, having these animal models that represent the different subtypes will again help us to develop the right medicine for the different subgroup of Alzheimer's disease. So that is really the overall thesis, or the main points that I want to bring to you this next hour. And so before I delve into this more, I just want to make sure that everybody understands these concepts. Do you have any questions? Maybe I need to clarify at this point before I move on. Okay, if not, it's clear to everyone. Okay, so just as a review, you guys all know about this person, Dr. Alzheimer's, who first described this disease with this index case, the first patient that in fact demonstrated to have the pathology of Alzheimer's disease. More than 100 years ago, right? He was a psychiatrist working in Germany to document the pathology that is seen in the brain of this patient. And what he saw basically is here, the two component, what we call the canonical pathology of Alzheimer's disease. That is the neuritic plaque, right? That is deposited outside of your brain, but on your brain surface. And then inside the brain, the second pathology is referred to as tau tangles, you probably might heard of. So neuritic plaque is really what we call these amyloid plaque, this cartoon here, whereas the neuritic, neurofibrillary tangles, or what we now call, these tau, aggregated tau proteins. These are proteins that actually accumulate inside the nerve cell. Okay, diagram here, you can see in the cell body of these nerve cells or in their processes. And so these are considered as the canonical pathology of Alzheimer's disease, that you see it in every case of a patient that have this disease in the brain. And these pathology eventually lead to the loss of these nerve cells in your brain that impact on learning and memory. So you can see a dramatic atrophy of the brain in patient with Alzheimer's disease compared to those that are healthy, right? And so these are really considered since he presented this case more than 100 years ago, this remains to be the case. To date, we still use these pathology at autopsy to define the patient having Alzheimer's disease. There are indeed genetic evidence that we know that impact on the genetic cases of Alzheimer's disease. These are people who have a history, a family inheritance of certain genes that predispose them to Alzheimer's disease. They represent only about 10% of all the cases of Alzheimer's disease. These are so-called the APP or amyloid, the precursor protein gene, or the presenilin genes that are deterministic. That is, if you carry mutations in these genes, you are sort of destined to get the human disease. generally are early onset cases between 45 and 55 years of age. But large majority of the Alzheimer's cases, not at least 90% of them, do not carry these mutations in these genes. Rather, they have a different set of genes that impact on these so-called late onset Alzheimer's disease that occur between 65 and 75 years of age. And the most predominant or most important risk factor or risk gene that we know is called ApoE, E4 specifically. If you inherit ApoE4, your risk of Alzheimer's disease goes up dramatically. And more recently, there are also other genetic perturbations that are less dramatic than ApoE, but they also contribute to the onset, the late onset of Alzheimer's disease. So as you can see, many of these genes that might be involved in the sporadic disease represent 90% of them are late onset, okay, as opposed to early onset cases that are more deterministic. But there are a variety of different factors other than genetic factor, environmental factor, or lifestyle factors that also could impact on Alzheimer's disease. Namely, age is really the most important factor that correlate with Alzheimer's disease, because Alzheimer's disease is an age-associated disease. But other than genetic perturbations, there are a variety of other factors like vascular factors, even sleep or your cardiovascular system, your immune system, microbiome, and metabolic factors could all contribute in part, perhaps together with some of the genetic perturbations that predispose us to Alzheimer's disease. But I think some of the most important factors that we identify over the last 5-10 years that actually now become part of this subtype of Alzheimer's disease that I'm going to tell you about are these so-called non-canonical. They're not the initial ones that Dr. Alzheimer's described. These are other pathology that involve two other proteins. One is called alpha-synuclein protein. You don't have to worry about these names, but this is a protein that's particularly involved also in Parkinson's disease. Also in Lewy body dementia, you also have accumulation of this particular protein that's different than the amyloid protein that come from the APP gene or the tau protein that gets aggregated in the brain of human disease. And the other protein is called TDP43. So you don't have to worry about these names, but just to know that in addition to the amyloid and the tau protein, these are the two other proteins that also form a major part of the pathology that we now see in different types of Alzheimer's disease. So what I mean is this: if you were to examine, 100 cases, 100 brains of people with Alzheimer's disease, initially what we thought, there are primarily these people with the amyloid pathology, right? So you know all about that. Using brain imaging studies, one can visualize these amyloid plaque that are littered throughout the brain of the Alzheimer's patient. And then intracellularly, right, inside the neuron of these brain cells, you accumulate this tau protein. So again, these are the pathology that's first described by Alzheimer's. But if you were to look at the other components, right, other than so these are referred to as the pure kind, right, that comprise of the tau protein or the amyloid protein. But in addition to that, a third of them not only having amyloid or tau problems, they also have this alpha-synuclein protein that I just told you about. So that's a major subgroup, right? And then the other third, right, other than amyloid and tau, you also have this TDP-43 pathology, okay? So that means you have, for these people, right, you have 3 different types of problem, amyloid, tau, and alpha-synuclein. And for this group, you have amyloid, tau, and TDP-43. But worse yet, there is a smaller population that actually have all 4 pathology. That is not only amyloid plaque or tau tangles, they also have this TDP-43 pathology and alpha-synuclein pathology, right? So you can see, and even with different stages of the pathology in different brain of patients, you could see these 4 major subgroup of Alzheimer's patient, we think. The reasons is because when you have these additional pathology, for example, if you have TDP-43 pathology, as I said, a large percentage of these cases, 80 cases, do show the same pathology. The important thing is that when you have this additional pathology, your outcome, like your cognitive outcome, and the nerve cell that are dying in the brain is worsened compared to those without this co-pathology, without this additional pathology of TDP-43. So that tells us that when you have additional pathology, it will worsen your cognitive decline and your neurodegeneration, okay? And likewise, the same evidence that can be derived from the alpha-synuclein pathology, right? So the other pathology that might represent even up to 50% of the cases of Alzheimer's disease. And if you carry this additional pathology of alpha-synuclein, your cognitive decline gets worse and your nerve cell die to greater extent. So what this information really tells us is that there are these 4, so I just diagrammed it here for you, that you have these 4 subgroups, right? This is sort of the pure group where you have only amyloid and tau pathology. But you can have a subgroup that have, in addition to that, the TDP-43 pathology. So again, these are pathologies that accumulate this specific protein called TDP-43, which I'm going to tell you a little bit more about, in the nerve cell in the brain of these patients. They get aggregated, sort of like the tau protein that gets aggregated, gets clumped up in the nerve cells. And likewise, alpha-synuclein, this protein also gets accumulated and aggregates in the nerve cell in the brain of these Alzheimer's patients. And worse yet, of course, if you carry all 4 pathology, these are the patient that gets the worst cognitive decline compared to these other ones. So why do I bring this up as an important hurdle that we need to address? The simple reason is this. Even with our current drug trials, and in fact, for the last 20 years, we actually consider Alzheimer's disease as one disease entity, and we treat everybody as if they're just one problem, right? That we're going to have a drug and we hope to treat everybody. But now, as you can see, if these all 4 major groups actually exist in the population, and then when you bring in all these different people into the clinical trial, you're going to have a wide variability, right, of cognitive decline, because each person will decline at a different rate. The one with all 4 pathology will decline much, much greater than those with only the 2 pathology. That means you have a wide variability when you go into a clinical trial, because we don't know who has what. And if you think you can have a drug, right, that will fix everybody, right, and find a benefit signal among these high variable kind of measurement that you have to show that your drug could have a benefit, is very challenging, right? So you might need to have a clinical trial that will involve 1,000 or 10,000 patients to really find a specific beneficial signal. So that is the major reason that we really need to stratify these subgroups so that we can actually recruit them according to their subtype or their pathology, so that we can test drugs that will be specific to each one of the subgroup. And in that way, I think we have a better chance to show whether your drug will have a dramatic impact on these subgroups of patients. And so that is really the one major hurdle that we have not overcome, because we do not have this ability to stratify these subgroups of Alzheimer's patient in this manner. And the other important issue is, of course, how these different pathology might influence one another in the brain. We have no good understanding because we don't have good model system to begin to tease out how each of the pathway intersect or interact with one another. And so that it remains to be a major focus in the field. If we are able to sort that out, then that actually will help us immensely in terms of trying to develop very specific drugs that will impact on those pathways that and how they interact to come up with a very useful drug to tackle these different subtypes. And so those are really the two major problem that I see that we really need to resolve as a field, to move the medicine to come up with medicine that will help us to solve this problem. And so we're not at a loss, because now we actually are at a point where we are beginning to allow us to come up with these blood tests to stratify these subgroups, so that we can now begin to stratify patients according to what we think their pathology might show in the brain, okay? And then we can also come up with model systems that will allow us to begin to understand the interaction between these pathways, so that we can understand the root causes of these interactions, so that we can come up with better drugs. So does that make sense to everyone? If you have any question at this point, I'm happy to answer and clarify them. Norman, please. You're muted.
My wife was 50 when she started showing the signs, and I took her to Duke University I kept up with the clinical trials, and they tested her, and she failed each one. So that so evidently they were looking for a certain skill level, or so it just bothered me that they would not. But are these 4 boxes that you're showing, is that over a period of time? Why are the drug that we have now only works on early onset, the first drug in 117 years? So are you trying to hit a moving target here, doctor?
Oh, right. So that's a great question. So what I'm trying to illustrate here is that the realization of the complexity of the disease only came to the fore in these recent years, so that we can, in fact, understand the disease to a greater extent. So it is, in hindsight, right? In hindsight, you might feel that, yeah, this might be a moving target, but because it's our lack of complete understanding of the disease that might, in fact, give us this thinking, right? Because these information only come out in the last 5 years, 7 years or so. So I'm not sure whether that helps. Okay, any other questions before I move on? If not, let me do that. So I think we, at this point, delineated a major hurdle, a stumbling block, if you will, right, in Alzheimer's disease, and that we, with the new drugs that is coming on board, we already know that some of these patients will respond, but we need to find out who those are, and then we can deliver the right medicine. So the one critical information, right, is understanding, as I said, the different subtype to understand better the root causes of this subtype that will enable us, therefore, to develop better therapies. And then the other one is to come up with blood tests that will help us to differentiate the different subtypes. And so we call these biomarkers, right, that will allow us to do a blood test and show us which of the subtype one might have. So one of the understanding of, so you don't have to worry about this complex diagram here, but what I just want to illustrate is that, you know, while there are different risk factors that impact on disease, both genetic, environmental, one of the key elements we think is this tau problem, okay, the tau protein that gets aggregated. And we think that the amyloid plaque, right, remember I told you about these are the amyloid that accumulate outside your brain, and they actually contribute what we think as the first hit to facilitate this bad guy, this tau, from a good tau protein into a bad tau protein. And that's the bad protein that then drive these accumulation of these neurofibrillary tangle, or these tau tangles in the neuron, and causes the neuron to die, right? So we think that the central problem is really converting this good tau protein into a bad tau protein. And there are numerous factors that could do that. And one, we think, is the amyloid protein that facilitate this process. There are also other factors, such as inflammation that occur in our brain, or this particular protein called TDP-43, which I talk a little bit about, because this protein, when it's lost, is able to impact on the tau and accelerate this bad tau pathology to drive the neuron loss. So this is what our current understanding is in terms of how this protein, TDP-43, right, drives this problem. And the way that we tested this is to utilize this mouse model that we generated a few years ago now, that we think is the best model to model the pure types of Alzheimer's disease. That is, Alzheimer's disease that have only the amyloid and the tau component of the pathology. Okay, so this model we now show, in fact, could mimic what you might see in the Alzheimer's brain. They, in fact, develop these amyloid plaques like you see in Alzheimer's brain, or the tauopathies that you see in Alzheimer's brain, and they also lead to brain atrophy. So all these key features that you see in human disease is mimicked by this model. So we're able to now take advantage of this to therefore test whether how the other component, how TDP-43 might facilitate conversion or make the good tau into a bad tau. So the way that we approached this was to take this mouse model that carries what we now think is a seeding process. It's a seed of this tau protein, which normally doesn't do anything, but until you present it with the amyloid component of the disease, then you allow the conversion of this tau protein to happen, and that's when the bad tau will drive the neuron loss, the nerve cell loss in the brain, and that we think is what's happening in human disease. And so now using this model, we can now begin to ask how TDP-43 actually interface or impact on this process. So I haven't told you about the pathology yet, but now I want to spend just a couple minutes to give you some background about this TDP-43 pathology, right? So this was first initially discovered by Virginia Lee's group back in 2006 in ALS. Remember, ALS is a non-neurodegenerative disease, amyotrophic lateral sclerosis, or frontotemporal dementia is another type of dementia that involve human disease, that occur in human disease. But this pathology, again, is when this protein gets clumped in the cell of these nerve cell of these patients. Normally, they live in this sort of the nucleus, so called the nuclear compartment of the cell. But in human disease, they just clumped up like this. So you can see here, you can see here. They get out of this nucleus of the neuron, which they usually, normally, that's where they reside, that's where they do the normal function. And in fact, in AD patient, in this particular case here, you can see many of these cells, right? They don't have this nuclear TDP-43 anymore, suggesting that you actually lose this particular function of this protein. And that we think is the underlying problem in human disease. But I won't go into much detail, but just to briefly tell you, this is more complex than what you like to know. But basically, the normal job of this protein is to protect the gene function of many genes, right? By controlling how the RNA gets properly made so that you can make a normal protein. Okay, so essentially, it's a protective function in the neuron, in the cell. So I call it the guardian, right? The guardian of the transcriptome just means that each cell has the coding capacity for every protein in your cell. And so the RNA that's responsible, right, for generating all the protein in the brain is normal, because you have this protective function that won't disrupt the generation of these RNA. Because if you lose this function, you create a lot of havoc in terms of messing up the RNA coding capacity. So you actually generate bad protein in your body, and that's how you lose the ability to function properly, and so each of your cell will be messed up in many ways. And so this becomes a very critical function in governing the function of your cell in your body, in your brain. So we then begun to assess whether we can take advantage of this discovery, this idea, to help us to identify biomarkers, right? So right now, as I indicated, biomarkers are a way that we can test in in your blood to see if you have any of these problems in terms of amyloid tau, right? We already have good biomarker for amyloid and tau, both from imaging, right? From PET studies, that you can visualize these pathology in the living patient, right? And we also have very good biomarker to test in the blood and or the CSF, the cerebral spinal fluid, right? That's the fluids that bathing your spinal cord. You can sample them, and you can actually find evidence of these biomarkers for amyloid and tau. But we yet have the imaging biomarker that are good for these other 4 subtypes, the other 3 subtypes, right? Because we don't yet have good biomarker developed yet. But we are on our way. So the next one I'm going to talk to you about is this biomarker for TDP-43. And so we now are able to develop, in fact, a blood biomarker to detect whether you have problem of TDP-43 from your blood. And so what we are able to show now is that using this biomarker in CSF or in blood of patient, you don't have to worry about the name of this biomarker, but it actually comes up very early on in human disease. It comes up even before nerve filament. So this is another biomarker that people have been using to gauge the state health status of the nerve cell in your brain for Alzheimer's disease. And it comes much later, okay? But now we know this biomarker actually comes even earlier, it peaks even earlier. So that gives us a very good handle now to help us to at least stratify this one type of AD subtype that involve not only amyloid tau, but also TDP-43 pathology, okay? And other people, I don't have time to tell you, but they are indeed interested in developing the alpha-synuclein component of the biomarker. And now having all 4 becoming available, right? Then we will be able to turn these no's to yeses, right? So in the future, what I'm predicting is that we will be able to develop a blood test that will allow us to show which of this subtype these AD patients might have, because that is very important, as I told you in the beginning, that for clinical trials, if we are able to do so, we can actually select and purify very pure groups of subgroup of patients that we can bring them into clinical trial with the right medicine, right, to target them and effectively help them with their cognitive decline. And so, so the other piece of the puzzle, as I indicated, is that we need additional model systems to represent these subtypes. So because my time is almost up, I would just simply tell you that we now have developed such a model system where it now comprises not only the amyloid component, the tau component, but also the TDP-43 component of the human disease in the same mouse model. And other people also have developed or begun to develop the one for the amyloid, tau, and the alpha-synuclein component. So in the future, I think we will have a much better position to beginning to understand and clarify these disease mechanisms, right, which are the root causes of these subtype of disease are still not clear. So in the future, we think we'll be able to clarify this using these appropriate animal model systems. And once we have that in place, then this will allow us to use these model systems to test combination therapies. Because I think we do not, there's not going to be a one silver bullet, right, that will take care of all of these subgroups. I think the current drug will probably do very well for the pure non-canonical type of pathology of amyloid and tau. But for the other subgroup, what I think we'll need is combinatorial therapy, having let's say a tau drug combined with a TDP-43 drug together will help with this group of patients. Likewise, a tau drug combined with, let's say, alpha-synuclein drug will help with this group of patients. And then all four, we have to probably combine all three types of drug, like amyloid drug, tau drug, or with TDP-43 or alpha-synuclein drug. So I think that's where the future will lead us and will allow us to begin to divide and conquer, right? So we would not pull everybody into the same clinical trial, but really to subdivide them into the appropriate, bend them accordingly to their subgroup. We come up with the appropriate medication that will target selectively for these subgroups. And in that way, I think we'll be able to conquer this devastating disease in the future. And so I just want to close by thanking folks in my group that contributed to this work and my collaborators and at Hopkins and elsewhere around the country. And clearly the CART have initiated this work 20 years ago to bring us to this position. And I think we have a bright future ahead of us. And I want to thank you for your attention.
How effective are the BACE1, tau, and inflammatory treatments?
So so you're talking about the beta secretase inhibitors. Those trials have not been successful with the beta secretase inhibitor, which we in the early days have focused a lot of attention to, because that beta secretase is a terrific target to target the amyloid pathway. So one of the concern, of course, and you have to think clearly, is that when you target beta secretase, which occur early in human disease, in the human disease progression, right? Because we know amyloid comes up early, very early in the disease course, before you have clinical symptoms. But we are actually treating these patients after the onset of symptoms. And so you can imagine there are a lot of things already happening, including the tauopathy that we talked about, or the TDP-43, or the alpha-synuclein, that are causing other problems that you're not treating. And so even though it's the amyloid is a good target using the base as an inhibitor, but I think you need to deliver that at an early time, right? So you have to match the therapy that you're going after with the appropriate time of onset that is appropriate for that therapeutic strategy. So we cannot simply just, blindly treat at any given time. So I think that is the issue. So I think if we are able to treat with a patient that developed disease early and deliver early enough, I think the BACE inhibitor, or inflammation for that matter, would be beneficial. But that is a trial that we need to do at a much early time in the disease course of the patient. I don't know if that helps.
Yeah, that was my question. I appreciate your answer. I think what it sounds like to me, though, is, by the time it's detected, it's progressed so far that the treatment is very difficult. It's like you're running to chase something. But what I think from other diseases is doctors are very hesitant to allow you to do exploratory tests, i.e. maybe a PET scan to see if you see the amyloid plaque or the inflammation. They're very hesitant to do those. So it's kind of like the chicken and the egg.
Right. No, that's a good point. Yeah, you're making, Kara. I think we're now actually, the FDA is now allowing clinical trial to go earlier now. So we have these trials, what we call pre-symptomatic trials. So that is, these are the trials that people do not show the symptoms yet, but they actually have biomarker, for example, showing amyloid positive imaging, tau imaging, but neurocognitive decline is not occur yet. So they can recruit these patients, particularly those who have high risk genetic risk allele, like ApoE4 that I told you about. So using biomarker and genetic risk, high risk, then you can actually select population that might be at this initial stage where they are maybe close to onset of disease. And so you could now, FDA in fact is allowing one to begin to test these patients with some of these amyloid drugs. And so I think if you treat earlier, then I think you have a better chance to see a beneficial outcome. You're absolutely right. You know, when the horse is out of the barn, you cannot, or the train is out of the station, you can't pull them back.
We have just about 3 minutes left, but there is one more question for you in here, Dr. Wong. Are any of the funding agencies or organizations prioritizing research to meet the unmet needs that you've described today?
Right, that's a great question. So I think the NIH particularly is now very supportive and highlighting these critical areas. So they are referred to as Alzheimer's disease related dementia, right? Because they are relating to these other pathway. And so there is very strong emphasis in supporting grants application that are devoted to these other types of Alzheimer's related dementia that we've talked about today. Yes, and I think other funding agencies are doing the same thing. And so I'm very pleased, you know, that the NIH is really leading that effort to direct funding to try to help us to move to the goal line quicker.
That was an eye-opening presentation, and it's also very discouraging. Thought we were on track to resolve the tau tangle beta amyloid targets, and now you've given us a whole new series of targets to shoot for. But Dr. Levine in 2009 said the key to success in fighting Alzheimer's disease is early diagnosis. And I know we spent a lot of CART money working on blood tests, eye tests, and using the PIB isotopes to identify the amyloid beta. It sounds like this is a bigger problem now that we aren't even close to solving yet. Am I on track on this?
Thank you, Bill, for that question. You're right, and as far as that, you know, we have additional target to deal with. We certainly, you know, the amyloid and the tau targets are still not changed. They are still the principal one. What we are trying to suggest here is that that because of these additional pathology, that we have to be smart about how we go about testing, right? So the tau drugs that are in the clinic, the amyloid drug that are in the clinic, you know, could be very beneficial. The question here is, can we stratify these patient groups? Because we know that when you have this additional pathology, you're gonna be able to mess up your clinical trial, right? Not everybody's gonna be respond to the same drug. So I think that we are still on track, right, to getting these drugs into the clinic to bring them to the patient who needs them. But we just have to be very precise and very careful about how we proceeding with this, because we can shoot ourselves in the foot if we don't. So what I'm trying to tell you here is that it is very much like the lessons that we learn in cancer field. In cancer, we have face the same problem, 5-10 years ago. But now you see how cancer is really, triumphed over these last several years because of the realization that there are these subtypes, that you have to find the appropriate patient with the right drug to treat them. And that is the key here. And I think the lesson is the same here. So to your question, yes, there's a bigger problem that we have to deal with, but now we understand it better, and then we attack it smarter, right? And with the resources that we have, I don't think we are moving backward. That's clearly not the case, okay? We are moving forward, but we're moving forward with the idea that we can deal with the problem in much more smarter way, developing much more better tools and ways to help us to get to that goal line, I think. So I think your question is very well taken, but I think we have a lot of enthusiasm. I think the idea that some of these drugs is helping some people, right? Not all yet, because of the problem that I just presented to you. So we are just moving a step at a time, but carefully and cautiously. I think we're winning.
Wonderful. Thank you so much. Thank you, everybody, for joining us today, especially to you, Dr. Wong, for spending your valuable time with us. We are so grateful.